So it is 2:30. We're going to get started. Thank you for joining us for this media briefing about COVID-19 vaccine in Idaho. My name is Zachary Clark, and I am moderating the briefing today. Before we get started, I just want to say that we have received some questions from media this morning about the criteria used to move the state from one stage to another during the pandemic. The governor's office has updated the website to reflect that multiple factors are considered as Governor Little makes decisions about which stage the state should be in. For the purposes of this briefing today, we'll be focusing specifically on our number one priority, which is COVID-19 vaccine in Idaho. So today we'll be hearing from Health and Welfare Director Dave Jepson and Public Health Administrator Elke Shaw-Tulloch before we open it up for vaccine-related questions from media participants. Dr. Christine Hahn, State Epidemiologist, and Sarah Leeds, Idaho Immunization Program Manager, also will participate in the briefing. We will not be taking questions from the public at this time. Please note that everyone should be muted unless they are speaking. And with that, I will turn it over to Director Jepson.
Thank you, Zachary. Just want to confirm that you can hear me okay.
Perfectly fine.
All right, great, thank you. Well, welcome to our regular Tuesday vaccine press briefing. As of yesterday, 120, actually on the website today, we have 126,178 doses have been administered and 103,378 people have received vaccine. At the end of last week, which would end just there on Sunday, Idaho had received 221,550 doses. That's doses that have been received into the state and administered approximately 120,400 of those doses. That means that there are about 101,000, just roughly 101,000 doses received in Idaho that have not yet been administered. And what I'd like to do is break down what those doses are. So I'll move through the math here for just a minute. About 22,000 of those 101,000 doses that we've received are first doses. So we have about 22, as of Sunday, we had 22,000 first doses in the state. At the current administration rate, that is about 1 week's worth of first doses available. That means that right now, first doses are getting administered generally within 7 days when they arrive in Idaho. About 47,000, actually about 47,500-ish of those 101 are second doses. So I'll say that again, about 47,500 of those 101 that are in Idaho are second doses. And we have some more work to do to understand why the number of second doses not yet administered is higher than we were expecting. And then finally, the federal pharmacy program with CVS and Walgreens for long-term care facilities has about 32,000 doses of those 101,000 doses received for Idaho. And that includes first and second doses. CVS and Walgreens have indicated that they are not going to use all of those doses. And as a result, we worked with the local public health district directors over the weekend and have reallocated 6,300 first doses, or a total of 12,600 doses from CVS, which will be delivered this Wednesday to enroll COVID-19 vaccine providers in all 7 public health districts. That was for CVS. We are still working with Walgreens to determine how many doses we can reallocate from them, and we will work with the local public health directors on where to deliver those doses next week to enrolled COVID-19 vaccine providers across the state. Or to say that again, there's about 32,000 doses unadministered by the federal pharmacy program. We transferred 12,600 in total, 6,300 first doses this week, and we'll work with Walgreens to transfer additional doses for next week. Finally, we are anticipating publishing the number of doses received, administered, which would be shots in arms, and in inventory, which would be doses received but not in shots in arms, for each public health district and each enrolled COVID-19 vaccine provider Monday, February 8th, per the governor's executive order. Yesterday, February 1st, those 65 and older became eligible for the vaccine. There are roughly 265,000 people in Idaho who are 65 and older, But as a reminder, we are receiving about 25,000 first doses a week, and you just heard me mention as of Sunday we had about 22,000 first doses in the state. That means it will take several months to get through this group. We ask for your patience of the public and those that are 65 and older. Everyone 65 and older who wants the vaccine will be able to do so, but those appointments will happen over the next coming several months. I also wanted to circle back to the excellent questions about race and ethnicity. Last week, I had shared that the state statute does not allow the department to collect race and ethnicity data for COVID-19 vaccinations. After further investigation, it became clear that the Idaho statute does not prohibit the department from collecting race and ethnicity information. In other words, we are permitted to gather race and ethnicity information. However, there is also no statutory authority for the department or healthcare providers to mandate that patients provide race and ethnicity information. It's optional for patients to provide this information. The agreement that each enrolled COVID-19 vaccine provider signs with the CDC encourages but does not mandate the collection of race and ethnicity data. Given this new information, we are currently looking at what capability the state immunization system has to request, receive, and record race and ethnicity information from enrolled COVID-19 vaccine providers should they have that information from their patients. We will continue to work on that as quickly as we can to understand what we can do to collect data in this space. However, from a big picture view, the key thing is to ensure that race and ethnicity is not a barrier for those that want the vaccine. The department is taking many steps to ensure everyone who wants the vaccine has an opportunity to do so when they are eligible, regardless of race or ethnicity. So I'm going to hand it over to Sarah Leeds just for a second to discuss some of those efforts that are outreach to various race and ethnic groups. Sarah?
Thank you, Director. We, at the immunization program level, work on an ongoing basis on equity in terms of access to vaccines. And that is not just with COVID, but that goes to all the work that we do with pediatric vaccines and annual influenza. We engage in outreach and education, and we are always looking for ways to engage our partners in increasing education and opportunities to get vaccines among vulnerable populations, and look for ways that we can provide outreach to those folks to encourage access to vaccine. And so we have a new funding opportunity with the CDC, which provides us with a really robust way through funding to engage even more. And so we are developing those strategies right now with a lot of our partners, both in the public and private sector, to engage and increase vaccine access in vulnerable populations, including those across all race and ethnicity backgrounds.
Okay, thank you, Sarah. And I think we'll hand it over to Elke at this point. Oh, and I see there's a note that there may be feedback, and so if you haven't muted, please go ahead and mute.
Great. Thank you, Director. And I am going to put in a plea to our hosts that they give me sharing privileges here so I can share my screen. Currently, I'm not able to do that.
I don't think Elke has sharing. Oh, we're open to a participant.
And Nikki and Zach, they're not muted. We're having low bandwidth issues as well. So, well, I'll just go ahead and start, and hopefully they can get that resolved while I'm starting to speak. We ran into this problem last time, so my apologies, everyone. One thing that there are 2 points that I wanted to bring forward today, things to share with you all. And the first is to talk about our updated, fantastic, I see I can share my content now. No, I can't.
Share your screen.
Nikki, we can hear you talking in Zach's office. I'm just
Zachary, could you go on mute?
Thank you.
Thank you.
I'm going to keep waiting until I can share this content. So otherwise, I can always have maybe Nikki for me, or who's also watching can maybe share the screens for me, and I can guide folks through it. So the two issues that I wanted to make sure I address with you today, first is our updated website that we have. In presentations past, we've talked about PrepMod as a potential tool to be placed on our state website that would allow folks to go on and be able to access information about where they can go and get tested. What we have opted to do, I know there was some conversation about this last press conference, press briefing, but I wanted to make sure that you had an opportunity to really see what it is that we have available right now. And if you go to our coronavirus.idaho.gov site, right on that main landing page, what you can see on there is, oh, here we go. I can now share my screen. Pardon me, everyone. Technology is our friend, correct? So here we have it. So on our main landing page, here we go. We can be on a roll now. You can see on coronavirus.idaho.gov, this is our landing page that you see. Something that is new, recently new, is when and where to get your vaccination. So this is what we're providing that is our replacement for previous conversations that we've had around PrepMod. So this is where you as a person can go and find out more information about sort of who's right now in the queue being vaccinated, how you can go and find locations to sign up for vaccines. And so I wanted to walk you through this so you had some clarity on what its intended use is for and how you can navigate it. So as you can see on this site, when you click on it from that main page, the first thing that you can do is to find out if you can get your COVID vaccination. So this is where you can see sort of who's up right now. And as you can see, as of February 1st, vaccinations were open for adults aged 65 years of age and older. Talks a little bit about who is in that group. And based upon the supply of vaccine we have right now, approximately how long it will take to get through that vaccine. Of course, as the more we learn about additional vaccines coming into the state, whether that's an increased volume of the existing vaccines we have, or we get new vaccines that are made available. For example, we know that Johnson & Johnson, their new vaccine is in the pipeline right now. Once we have more supply coming to the state, this approximate weeks to vaccinate and move from this group to the next will be reduced. It also then shows you that vaccinations are continuing for all of these populations that have been previously prioritized by our COVID-19 Vaccine Advisory Committee. So we have referenced them previously as groups 1 and group 2. And then those recommendations, of course, were reviewed and modified, adopted, or rejected by the governor. And so this is our final list. We've seen it previously as well in a table format. So this is just an easy drop-down list of who is able to be vaccinated right now. And then a brief description of who is up next after the group that we're currently serving. You can see in early April is our estimate. Of course, always an estimate based upon the number of vaccines we have coming in and how quickly we're able to get them out. Is how soon it will take us to this next. This is right here, this early April. These bullets here indicate our the remainder of our frontline essential workers that our Vaccine Advisory Committee just prioritized. And then showing on here for late April and May are the next groups that we have. So this would be kind of considered group 3 and group 4, depending upon several factors. One being how the Federal Advisory Committee on Immunization Practices does their voting and their recommendations to CDC, and subsequently how our Vaccine Advisory Committee then votes on them. So, and then the governor's decision after that, of course. So this late April and May, those general groups will have more to come on that. The next part of this website that you can see is step 2 on where to get your COVID-19 vaccine. So this is the area that we had talked about previously about using that tool called PrepMod. And what we found is that the local health districts, in working with all of their enrolled providers, already had products and tools that they were using to direct people locally on how they can sign up for a vaccine, how they can find out where the vaccines are located, and they're using a variety of mechanisms to do that. But this chart on here is really to guide the user to find out where to go. And most of them have hotlines that they can call. We know, for example, age 65 and older need a variety of mechanisms. I just listened to a show on NPR this morning about seniors not necessarily being able to quickly navigate some of the provider portals to sign up for scheduling. And so it's really nice that we have this opportunity to have a phone number that people can call. So depending upon the area in which the person is located, you can either go online or you can call and get on a waiting list, get on in the queue to have a callback to get your appointment scheduled, and sometimes we go directly to the location. So I'm not going to click on all these for fear of messing up anything and ruining any technology, but I encourage you to go and look at those sites. And then finally, the last thing that we have on this site is what to expect at your vaccination appointment. So this is just a user's guide to what to expect, things that you can do after you get vaccinated. And then, of course, over here on the side is to learn more information about each vaccine as it becomes available. Right now we have Pfizer and Moderna. Those are the two vaccines that we have available, and then we'll add more as more vaccines come. So that is my high-level overview to give you an orientation on what we have available on our website. The other thing that I wanted to do with you today is walk you through, again, I did this last time, not last week, but the week prior, is to talk about that whole distribution, that kind of vaccine allocation, ordering, and distribution flow. I was verbally able to go through it with you, but we have a new tool that you can find on our site, and this is under the coronavirus.idaho.gov site. If you go to the vaccine tab, you can find this as a link on there in PDF. So this is the graphic that walks you through the process, and I think it's a really great tool to help you think about how vaccines actually flow in the state, because there's a lot of interesting and different perceptions of how vaccines are coming in, and we want to make sure that people are very clear how it actually works. So I walked through this last time with you, but I'm going to do it again, so bear with me. But this is a cadence that occurs every single week that's important to understand, and to also help you understand the state's role and the local health districts. I'll start with the federal role, the state role, and then the local health district role and providers. So at the beginning of the week, on Tuesdays, at the federal level, the federal the Health and Human Services puts into a system called Tiberius the weekly allocation estimate that's provided to Idaho. You've all seen and heard that estimates are based on population, and in this case on adult population. So it's preloaded for us at the federal level how much vaccine we expect to get for both first and second doses. And then on Wednesday, there's confirmation about what those numbers are. The IIP is the immunization program, the Idaho Immunization Program, shares that final allocation information with the local health districts, and afterwards adjust those doses as needed. So there's a conversation that occurs with the health districts, and then those health districts then work with those locally enrolled providers to talk about how vaccine will be distributed out within those providers, and then they finalize that per provider. So to narrow that down a little bit more, the health districts will, we tell the health district how much they are going to be receiving based upon what Health and Human Services confirms with us. That amount that the health district gets is based upon the group that we're currently serving for vaccines. So for example, right now, we're working on frontline essential workers, that's first responders, summarizing first responders, teachers, corrections and detention facility staff, and now seniors age 65 and older. So by health district, we look at the population estimates for those groups we're currently serving, and then tell them what their proportion of the doses are going to be for their health district. The health districts then work with their community providers and determine how much each provider will get based upon many factors, based upon their throughput, based upon their willingness to participate with a particular group that's being vaccinated right now, decisions that they've previously made about potentially big events that are going on. And so they work that out locally, and then they tell us by provider how much each provider will be receiving. And then the orders are placed by us as those plans are finalized. So as you can see, as you move over here to Sunday and Monday, all of that's being finalized. And then we at the state level then order those doses. So we place the order within that system called Tiberius. And then through that system, those vaccines are pushed directly from the manufacturer to the providers that have been enrolled based upon the number of doses that they have said they will be taking. So that's what that vaccine delivered means. It does not mean that it comes to the Department of Health and Welfare. We are simply that broker, if you will, for the Health and Human Services, sending a notification to the manufacturer, who then sends it directly to those enrolled providers. So as you can see, we start getting all those doses in the middle of the week, and then that process starts over every single week. We continue to go through that cyclical process. So I know there have been a lot of questions, and hopefully I addressed several of those in that overview. But that was my main tactic for today, was to walk you through those two very practical steps. One, to find on the website where and when you can get your vaccine, and then two, how that whole ordering process works. All of that is available through the coronavirus.idaho.gov sites. And with that, I will turn it back to Zach, I believe.
Hi, thanks, Alki. This is Nikki Forbingor. Zach is having some technical difficulties, so I'll take over the moderation from here on. So we will now take vaccine-related questions from the media participants. We're going to answer as many questions as possible in the time that we have available. Please raise your hand in WebEx by selecting the hand icon in the lower right portion of your screen. I see a few of you have already found the hand. You can also type your question into the chat area, which you can access also in the lower right part of your screen. When I say your name, please unmute yourself and announce your name and media outlet before asking your question. So today we're going to start off with Melissa Davlin.
Hi, this is Melissa Davlin with Idaho Public Television. I was looking at the county by county information that you just released on the new vaccine tableau at coronavirus.idaho.gov. And I noticed there's a strong correlation between the counties with the highest vaccination rates and the lowest number or percentage of residents living in poverty. So it's not exactly a one-to-one correlation between wealth and access to the vaccine, but there's a pretty strong correlation there. I was wondering, either Director Jepson or anyone else, if you wanted to weigh in on that access, because I wasn't finding any other major correlations as far as number of medical facilities or the age of the people who lived in the counties. The biggest indicator for that really was wealth and what I saw.
Great. That's a great question, and Melissa, and you originally posed it to the director, so I'll ask him if he wants to make any comments, and of course we have other folks on here as well to address.
Great. Thank you, Melissa. I always appreciate your excellent questions. They keep me on track, so thank you for that. We, as Elke just described, the distribution of the doses is proportional to the population that is in those public health districts, and specifically it's been based on number of healthcare workers, as that was the first phase, number of long-term care centers. As we move to the next phase, that was teachers and first responders, etc. And so that's the number of doses that we see, and that's how they're allocated. Has been based on those priority groups. Now, obviously, it's based on 65. So there's nothing in the allocation that would inherently be driven by income, from my perspective, because of those job classifications. So then the question becomes, are all of the health districts then doing an equal job of getting those doses out to those populations? And there is some, we'll be publishing this data on Monday, so you can take a look directly. But it is not the same across the state and how doses have been administered, how many number of doses have been administered. I'll stick with first doses. We do know, and as I mentioned in my opening comments, of our existing inventory, about 22,000, at least on Sunday, of those were first doses. And just to put a percentage behind that, that means Idaho has administered 82% of our first doses that we've received. And so given that allocation, given most of them have been delivered in the first doses, we're not sensing or seeing an economic bias in what's been done. I think the real place, and that's a place that I frankly worry about, is now, as we move into the 65 and older group, is really making sure we achieve that equity across not only race and ethnicity, but also income across rural and urban. Because this is really our first general public view, and I think that's the place we're going to have to be extra diligent to make sure that we're not disadvantaging any group because of a characteristic that they have. So, but I would say to date, I feel pretty good that we've been pretty equal and fair. I think going forward, it's going to be really important we continue to monitor that.
Okay, we're going to move on to our next person who has their hand up, and that's Audrey Dutton.
Hello, this is Audrey Dutton from the Idaho Statesman. I am curious what happened on Friday or over the weekend or late last week with the doses that were expected. The hospitals were expecting to get more than they did, both St. Luke's and St. Al's and across health districts. So I'm wondering, after walking us through the process and the cadence and things like that, it sounded like it would be at the health district level where that communication would break down, but it was across multiple different health districts. So I'm trying to figure out what happened. Can you speak to that at all? Do you know what happened?
Thanks, Audrey. And I know that probably the director and Sarah had a little bit more visibility into this, but you are correct. Those allocations do occur at the local public health district. They have those conversations locally. From my limited understanding of it, there was kind of a mix between there perhaps was maybe some communication issues. I'm not entirely sure, but also we know that there was an issue with some of the scheduling end of it through one of the larger hospitals, but I am going to ask if either the director or Sarah have more that they want to add to that.
Yeah, okay, I'll follow up to that as well. Thank you, Audrey, for the question. Obviously, our goal, the public health district goal, and the provider's goal for sure, is to make sure that every dose gets out, but that we also don't schedule people and have to cancel, and that's just unfortunate when that happens. We saw some of that happen over the weekend. I do not know the exact nature of where that breakdown occurred between the public health districts and the providers, and so I'll leave that to them to speak to. But it was the impetus for us to go ahead. We had been made aware earlier in the week that CVS was not planning to use all of their doses that they had been given for long-term care centers based on their information they had. And so we used that situation as an impetus to go ahead and reallocate some of those CVS doses. And I mentioned that in my opening comments, but to repeat, we took approximately 12,600 total doses, so that's 6,300 first doses, and allocated those around the state. But we did send several of those trays. They come in trays. Sorry to use that term, specifically to providers here in the Treasure Valley, so that they would be able to keep as many appointments as possible. So we were fortunate that we just out of chance had that opportunity to use the CVS doses. It gave us a really good reason to move quickly on that and to get those doses to those providers so they could keep as many of those appointments as possible. I do think that going forward, I think there was lots of communication about better communication. about the allocation that happens each week between the provider and the health district. So, and anyway, so that's just a little bit more insight into what happened over the weekend.
Okay, so I should check in with the health districts and the providers then?
Yeah, I knew that was where those conversations and decisions occurred, and I would be a little reticent to speak on their behalf.
Okay, thank you.
Okay, thank you. It looks like we have a question from Trevor Fay.
There we go. Can you folks hear me?
Yes, we can hear you.
Hey, this is Trevor with CBS 2 News, and something that I was wondering during the course of our conversation here is, in regards to the pharmacies, is there anything that individual pharmacies can do to lobby for additional doses of the vaccine, or is it all entirely based off of population for a given area?
Yeah, thanks, Trevor. I can, we'll use our team effort like we always do for these. Absolutely, the pharmacies should contact their local health districts in the areas that they serve to talk about that local distribution plan. We participated in several calls over the last few weeks with providers in the health districts, and typically they have groups that they bring together and they have those conversations. Certainly if they don't provide those vaccines on a kind of a one-on-one basis, we've seen efforts with the local public health districts and and pharmacy providers coming together to do high throughput events, kind of traveling strike teams, if you will. There's a lot of different kind of innovations for how they're getting vaccine out. So I would encourage every local pharmacy to contact their local health district. First step, however, of course, is that they have to become a COVID-19 enrolled provider if they aren't already.
And I'm sorry if I missed it, but what are the qualifications for that to become the provider?
I will let Sarah Leeds take that.
Thank you.
Mm-hmm.
There are many. They have to have a medical director. They have to have certain storage equipment. I mean, there are several pages worth of requirements that providers have to adhere to become a COVID vaccine provider.
What would you say is the most relevant for this situation, or the most common?
Relevant to vaccinating?
Correct, yeah, like the one that you would recommend these folks tackle first if there's a long list that they have to meet.
Gosh, that's a hard one. I think ensuring appropriate storage and handling equipment is one of the more critical pieces, because if you can't ensure the vaccine is stored appropriately, then it may or may not be effective. So I think that may be one of the more critical pieces, but they are all really important. Providers need to know how to administer the vaccine appropriately, how to report any adverse events. So, every piece of it, I would say, is really important, but maybe the first step is ensuring that they have the appropriate equipment, because without that, they can't keep moving through the enrollment process.
Excellent. Thank you.
You're welcome.
And Sarah, if I may add, Trevor, if you go to the coronavirus.idaho.gov site, under the vaccine tab, you'll see a big blue button that says resources for COVID-19 providers. And if you want to see what some of those requirements are, you can find out the list on that site.
Perfect. I'll be sure to check that out. Thank you.
Okay, I want to take a minute to just let everyone know that I'm pleased to be able to say that Interpreter Stubbs has been able to join us. If you would like to pin his video to your screen, if you scroll through the panelist videos, you'll see a little circle there with 3 dots in it. You can click on that and you can click pin this video to this spot. So I wanted to make that announcement. So we'll move on to our next question. This will come from Rachel Cohen.
Hello, this is Rachel with Boise State Public Radio. So yesterday on a press call, St. Luke's officials recommended people check MyChart multiple times a day because appointments could appear sporadically. I think that was further clarified that most of them would be open on Mondays. But clearly this is not something that everyone, even in the 65 plus category, can do. You know, check the website multiple times a day, call around to all providers who might have vaccines available. But this seems to be the system that the largest health district in the state is relying on. So I'm wondering what the state is doing to ensure equity in this case, that it's not just people who have time and connections to call around to see where vaccines are available, that just want to hear more about the equity.
Yeah, thank you, Rachel. It is incredibly challenging and definitely an imperfect system. And it's not just Idaho, it's every single state. I like I've mentioned before, I'm on multiple calls a week with my peers across the country, and everyone is facing the same situation and trying to make sure that we're doing the best we can to provide opportunities for people to get their vaccine, everyone who wants it. So, I know that many of the health districts, or all of the health districts, are trying to find those opportunities for people to have a variety of mechanisms to connect with a vaccine provider, whether that's, like I mentioned, through a phone call, but we know that there are long, phone trees that are going on, or long wait times. There are definitely the website situation and trying to make sure that you can keep checking back and finding those available appointments. I think as we get more vaccine into the state, it's definitely going to help that, because there's going to be more appointments available that'll make it much easier. But we are working with our health districts and through our communications office to make sure that we have chances for people to reach out and try to meet populations where they are, whether they have their local pharmacy reaching them, or they have their local public health district sending flyers, or holding events locally to help people navigate that. I think we're going to have to see more and more novel solutions to that as we move forward, because the population, it's a large number of people, obviously, and we need to employ a lot of different ways of connecting people to those appointments. But we continue to work with our health districts on an almost daily basis, trying to help resolve any issues that we can, and however we can do our best to communicate, we certainly will. And Director or Sarah, please, if there's anything you want to add, please do so.
Yeah, okay, I'm happy to. This is Sarah. We have outreach and education staff, and then a communications support system behind them that are working to have those mechanisms in place for folks who maybe don't have technology access and time to call every day. The way we'll be able to implement those methods when we have more vaccine, just like you said. So those plans are in place, or they're in, we're working on those, and we just can't implement them right now because of the limited vaccine.
Okay, our next question comes from Kyle Fonensteel.
Hi, I'm Kyle from the Post Register in Idaho Falls. I guess just a quick follow-up on what you said, Sarah. What are those systems going to look like? Is that going to go through the state or local health districts for ways people can equitably connect with vaccine providers?
Well, I think it'll be different in different regions of the state, and it'll be different as we look to work and increase vaccine access in different populations. And so we're looking to be more culturally aware and listen to the groups who represent those populations, and work to distribute the vaccine in the ways that make sense. And so, whether those might be in vaccinations in churches, or opening up, a mobile clinic, taking it to agricultural workers and things like that. So those are the things that we're doing.
I also wanted to ask about the governor's executive order last week required that vaccine providers report their inventory daily. I'm wondering, to what extent were providers reporting either to the state or local public health districts their inventory, and how was their inventory used to change any allocation formulas?
Yeah, I'll start that, and I will probably call on Sarah to follow up with that. We do know that, with each local public health district, they, like I said, they have those relationships already established with those enrolled providers. And so a lot of times they're having almost daily conversations with them about what they have going on locally, what their inventories look like. We can see certainly in our immunization, in our ordering system, what inventory they have on hand. So with the reporting, I think there's still some areas that we need enhanced so we have better visibility into exactly what's going on with those, because we know, for example, some of them might have what looks like a high number of inventory, but they might have a what am I trying to say, a high throughput event or some sort of mass event that's being planned a few days later. So some of those nuances are a little bit challenging to see just at the highest level, but those local health districts typically have a decent handle on what those providers have on hand, but definitely more visibility, more clarity is needed, hence the executive order. But Sarah, I'm going to let you maybe tag on to that, or Director, if you have more you want to add.
Yeah, I think you've summarized it really well, Elke. I don't have anything else to add.
And then I think the only thing I would add is one of the reasons we want to make that information public is several reasons. One is so you and all of the public can see who has doses and where the inventory is. I think that also encourages if there are situations and that a provider has started to build up inventory, we want that to be both public as well as visible to the public health district, so that a conversation can be had to say what's the situation there. And as Elke mentioned, it could be they have a bunch of appointments for a high throughput clinic in 3 days and they have inventory for that, or it could be that they're having trouble getting their doses out because they have staff that are out sick or whatever the case might be. So that can then lead to a conversation that says, well, what do we need to do about that? Do we need to transfer some of those doses to somebody else who has a need? Do we need to leave it where it is because that's going to rectify it? And those conversations would happen at a public health district level. So there's not a hard and fast rule that says, hey, if you have one dose that's longer than 7 days, here's what happens. What it really is at this point is a tool so that we can all see what's happening and we can have the right conversations to make sure that we accomplish the goal that the governor set out, which is that for all these first doses that come in, that happens within 7 days of receipt. And as I mentioned at the beginning of this call, that they're actually just starting to get our first look at this level of data this week. We realized we had 22,000 in inventory on Sunday. That's actually less than we're administering as a state each week as first doses. And so at this point, we're feeling much better that doses are getting out into arms and it's within 7 days for first doses.
Okay, we'll move on to Kim Fields. Kim, I'm going to unmute you.
I'm on my phone. Can you guys hear me?
There, now we can hear you.
Okay?
Yep.
Oh, perfect. Hi, Director. It's Kim Fields from KTBB. Kind of going off what you were just mentioning. First, I want to clarify, is it 22,000 or 12,000 that were reallocated from CBS?
Kim, this is Director Jepson here. Yes, what was reallocated from CBS was about 12,600 doses. That includes both first and second. So if you break it down to number of first doses that were reallocated from CVS was about 6,300.
Okay. So then kind of following up on that, you mentioned 101,000 doses are unused in Idaho. So where are the other 88,000 doses that haven't been administered yet? And why is it taking so long to figure that out?
Again, great question, and I actually ran through that a little bit in my opening comments, but let me just go through that here in a little bit more detail. We had on Sunday, we had about 101,000 doses that had been received by Idaho that had not been administered. And so let me just run through, now that we actually have some better visibility, where those doses are. Of those 101, there were about 22,000 that were first doses. So of the 101, there was about 22,000 first doses. And again, I'll just comment, that's actually less than a week's worth of inventory, or meaning we're actually administering more than 22,000 first doses a week. So basically, we expect, right now we're seeing that doses are getting out, first doses are getting out within about 7 days. Next is second doses. So of that 101,000 doses that had not been administered, we have 47,500 second doses in the state. And that's higher than we were expecting. So we actually have some work to do to understand what's happening with second doses. Second doses are shipped a week early, so we do know that they sit for a week and then before they can be used, and then the appointment has to get scheduled. But that's still higher than we were expecting. So that's the second group. So again, 22,000 first doses, 47,500. These are approximate second doses. And then finally is the federal pharmacy partnership. That's with CVS and Walgreens that is administering doses to long-term care centers. And they had 32,000 doses that had not been administered yet as of Sunday evening. So that's the third chunk of doses. Of that 32,000, we reallocated 12,600. And I should say that 32,000 with CVS and Walgreens is both first and second doses. So of that 32,000, we reallocated 12,600, or again, 6,300 first doses that was sent out, reallocated over the weekend, and will arrive on Wednesday. And then we will continue to work with Walgreens this week and plan to make a reallocation from Walgreens back to other providers for next week, and we have not arrived at a number for that. But just to summarize, 22,000 first doses, 47,500 second doses, and 32,000 with the federal pharmacy program is where those doses are.
Any idea why they were sitting on them?
I don't know if sitting on them is an accurate characterization. I think they were working through the facilities. It's my understanding that CVS is finished up, or will have finished up in the next day or two, all of the facilities they had. Walgreens is still working through theirs. And I would guess that they've either had a lower uptake than they expected, or there was an overestimation of the actual number of residents and staff at those long-term care centers. So we're not sure exactly why they had so many extra doses, but once we realized that that was the case, they were very, very forthcoming and very willing to reallocate them back to the state.
Great, thank you.
Okay, our next question is going to come from Hyatt Noramine. I'm not sure if I'm pronouncing your name correctly, but
hi. Thank you. And can you hear me okay?
Yes.
Okay. I just wanted to get a better picture of the immunocompromised category. So you mentioned that there were 265,000 65 and older. I'm wondering if you have an estimate for how many are categorized in the high risk with medical conditions. And a second part of my question is, my understanding is that the CDC recommended having first 75 and older, and then in the second group, have it be 65 and older plus those with high risk medical conditions. So I'm wondering if you could elaborate a little on the decision not to include them in this.
Yes, thanks, Hyatt. I can touch base. I have Dr. Hahn also on the call, who has been helping to support our COVID-19 Vaccine Advisory Committee. But I will start at the highest level and say that I'm going to jump to the age grouping first, because I don't have the numbers for people in that high risk category off the top of my head, that population estimate, although we do have it available. I just don't have it off the top of my head. But yes, you're correct. CDC did recommend, through ACIP to CDC, recommended age 75 and older being in that group. When we brought that forward, because as I mentioned, I think I mentioned on this call, that our Vaccine Advisory Committee has most notably been following the CDC/ACIP guidance as it comes forward. So when that decision was made by CDC, we brought that to our Vaccine Advisory Committee and had them weigh in on if we should open up to age 65 and older per the CDC the guidance. With that, we had several members of our vaccine advisory committee and the public send in comments and questions about extending that group to age 65 and older. We looked at all of our data related to kind of what age groups are actually contributing to hospitalizations, what are the population numbers, kind of looking at that whole epidemiology piece. And through that process and through those discussions, the Vaccine Advisory Committee recommended to the governor to lower that age limit down to age 65. So that was what was recommended to the governor, and he accepted that recommendation. And I'm going to turn it over to Dr. Hahn to see if she has anything that she would like to add to that. She also sits on ACIP calls.
Yeah, thank you, Elke. Can you hear me okay?
We can.
Yeah, so as you said, we and sitting on the Advisory Committee for Immunization Practices with CDC, I can tell you that at the federal level, as well as at our state level, none of this is easy. There are passionate arguments made for age-based vaccination. There are passionate arguments made for essential workers. Again, talk about health equity, people who have less access to health care. And there's merit in every position. So as Elke mentioned at our advisory committee meeting, we actually offered, I think we gave them 4 options plus kind of I believe it was like an opt-out, none of these look good to me type of thing. And what the first one was, hey, are we going to follow the CDC current ACIP recommendation for 75 and above? But we also had heard so many people interested in the 65 and above that we offered that as another option for them to vote on. It's all public. You certainly can go, I think the recordings, Nikki, correct me if I'm wrong, I think the recordings of those meetings are available. If not, we certainly have notes from the meetings and all the presentation slides that were presented. And of course, the meetings themselves, any of you all can listen into. So there was discussion, and as Elke said, they voted to lower the age to 65, and the governor accepted that recommendation.
And the second part of your question was regarding the number of people in that high-risk category, that age 16 to 64. And as we
have that, Elke.
You do? Okay.
I'm sorry. I should have brought that up. I'm sorry. I had that pulled up because I thought we might get asked questions, and like you, I can't keep all those numbers in my head. So as the question was for 1864 with high-risk conditions, the estimate is 371,127. That is the population estimate that we will be working with as we look at that group.
Thank you. And my question was more targeted towards why the immunocompromised ended up not being included. Was that one of the options to vote on, or it was more about that than the 60, broadening it to 65 and older?
Hyatt, Elke, I can try to take a stab at that. So CDC has a published list on their website, and if anybody, I can grab it after I'm done talking and throw it into the chat, but they list conditions that have been shown to increase the risk for COVID and severe COVID disease. And we are following that list at present for what we're considering high risk conditions. So I'll try to throw that list into the chat, but that is what so far we've been using. And anything was on the table. We provide options for advisory committee to kind of help start the conversation, but the committee itself can propose other groups and other individuals as well. So we don't limit their choices.
Okay, we will move on to our next question, which comes from Shira Matuzawa.
Hi, Shira from KTVB here. Can you hear me? Okay, perfect. So we've received reports that certain organizations have jumped the line in front of others when it comes to getting the vaccine. How is this possible, and are you guys investigating anything like this?
Yeah, thank you for the question. Certainly, we know that it's challenging on the provider end to manage all of the different population groups that are coming through the queue. We're not policing that. We're strongly encouraging, providers are doing the same to make sure that they are vaccinating the people in the priority group at the time at which they're designated. So while we do, I know that the local public health districts, for example, when they hear about it with a provider, they talk to them about it. We have even seen situations where at times the providers are maybe out of appointments and they're wanting to dip into a different priority group that we're not currently vaccinating. So the health district has worked with them to reallocate those doses elsewhere. So they're trying to stay on top of it as much as possible. But as you can imagine, when we're doing thousands and thousands of doses a week, and we have hundreds of thousands of people that are lined up and in queues, it's nearly impossible to manage every single person that's going through. But I would say overall, given what we're doing in Idaho and the nation, we're doing pretty darn good. I think people are being very respectful of the priority groups that we're in. And I hear great stories about people's excitement. They're anxious to get in, but they don't want to cut the line. They want to do what's right. And I would say that that's the pervasive sentiment that we're hearing about. But we just want to make sure that we also get those messages out there as well. Please stick with your priority groups and also be patient and knowing that some of those priority groups are going to take a while to get through.
Thank you.
Mm-hmm.
Okay, we'll move on to a question from Katie Clark. And given the fact that it's now 3:27, this will be our last question today.
This is Katie Clark from the Idaho Business Review. Last week, the governor said that Idaho has been receiving fewer vaccines on a per capita basis than other states, and that the state of Idaho would be seeking clarification from the federal government as to why this was so. Has there been any clarification or response received back about this matter?
Thank you, Katie. And I'm going to turn that over to the director to see if he's had any recent conversations, and we can round that out with some further information.
Thank you, Katie. Excellent question. We have had conversations with our federal partners. And the first piece of information we learned was that the allocation is actually based on adults 18 and older in each state, not total population. And it depends on which data source you look at, but Idaho has the second or third highest proportion of children, or those under 18 of any state in the country. And so that actually reduces our allocation a bit, because we then look smaller than we would normally. And then secondarily, it appears that they're using data that is from not the most recent census data. And being a rapidly growing state, that means that number is probably even smaller than it should be. So we have continued to raise with our federal partners that we think we are not where we need to be in terms of our allocation compared to other states. I think it's unlikely they're going to reduce allocation in other states, but what we're asking is, as we go forward, that we get that recalibrated so Idaho does get its fair share of vaccinations. So I can assure you that's an active conversation that takes place regularly, and something that's really important to us, that we fight for Idaho to get at least its fair share of doses. Nikki, you're muted, I believe, there, Nikki.
Thank you, Director. Sorry about that. So that does bring us to the end of the hour we had planned for this. We are planning another media briefing about COVID-19 vaccine in Idaho at 2:30 p.m. Mountain Time next Tuesday, February 9th. You can watch for those details on Monday, and thank you for joining us today.